hyperthyroidism, hypo, goiter, and thyroiditis. Um, so just to recap, I think a lot of you have gone through these things in endocrine module. What is meant by hyperthyroidism? It's mainly due to clinical state due to elevation of thyroid hormones in the circulation. Mostly due to increase of the synthesis of thyroid hormones, but very rarely can be due to excess in the release. Is anybody recording the lecture?
Yes, sir.
Yeah.
I'm
Yeah.
Supun, sir.
Yeah. Supun, because we need to record and
Yes,
update.
sir.
Yeah.
I
Okay.
and Dr. Sajid, both we are recording this lecture, sir.
Okay.
Okay.
Yeah.
If you want
So
to record, you are also allowed, sir.
yeah, but if you are recording, that's fine. Okay.
Okay, sir. Okay.
Yeah. Just to again recap the causes of hyperthyroidism, it's mostly either Graves' disease, but sometimes it can be due to toxic multinodular goiter or adenoma. Other ones are quite rare, but we rarely see them. And then the clinical features are due to the excess thyroxine, which increases our basal metabolic rate and other metabolic activities, as well as due to the increased sensitivity of the beta adrenergic receptors due to the permissive action of the thyroxine. And if you know these two, you can easily work out the clinical features, because when there's increased metabolism, there's increased heat production in the body, and as a result there's a need for increased dissipation of heat. So the mechanisms that are important for increased dissipation, like increased sweating, so there has to be more blood circulation, as well as the blood circulation increases because of the increased activity of the beta adrenergic receptors. So the heart rate increases, then the cardiac output increases, so you can get palpitations, and then you can get tremors, and then the heat intolerance, and as well as when there's increased metabolic activity of the muscle, you can get myopathy. And also when there's increased activity of all the muscle groups, including the smooth muscle cells, there's increased gut motility, and even sometimes you can get diarrhea. And all these can be easily worked out if you know what happens with excess thyroxine. So you guys know that the Graves' disease is due to TSH receptor antibodies, which acts like TSH, stimulating the thyroid gland. And the unique feature in the Graves is that these autoimmune phenomena not only affects the thyroid gland, but also affects the eyes. And then there's excess soft tissue deposition in our orbits, which leads to protrusion of your eyeballs, which manifests as exophthalmos. You can see in this eye, you can see the white of the eye from the lower limbus and the lower eyelid. This is called exophthalmos. And you can see the upper, between the upper eyelid as also the upper limbus. This is called lid retraction. This upper lid is retracted due to the sympathetic overactivity, which contracts the levator palpebris superioris. In addition, you can see there's increased redness, conjunctival injection and chemosis, and there's some edema. And also you can see around the eyes, there's periorbital swelling. All these are features of Graves' disease. But this the lid retraction can occur in any form of thyrotoxicosis. You can see the diffusely enlarged thyroid gland with the eye signs, and severe form of eye disease, severe chemosis and periorbital swelling. This can be the vision threatening as well. Sometimes because of the edema, the optic nerve can undergo compression, and optic neuritis can happen, as well as vision can get affected due to severe corneal, affection, and which can even lead to corneal ulceration due to exposure. You see, this is called, the sign is called lid lag. The upper lid lags. Usually, if you do, you ask somebody to follow your finger, the upper lid should follow the eye. Here, there's a lagging of the upper lid called lid lag. And then you can get onycholysis and also pitting of the nails. All are signs of Graves' disease. This is called pretibial myxedema, soft tissue deposition on the, and particularly on the shins and the dorsum of the feet. This can rarely happen in other areas as well. So to confirm diagnosis, when you have suspicion, usually TSH can be sufficient, but at least at the beginning, we tend to do TSH and free T4. Free T3 is done if there's a doubt where TSH is suppressed, T4 is normal. So in T3 toxicosis, this can be the picture. To find the cause, sometimes these tests can be useful, particularly if there are no classic signs of Graves' disease and you want to confirm the diagnosis. The TRAB antibodies is positive in Graves' disease. The uptakes can help us to distinguish between different causes. Uniformly increased uptake in Graves, one solitary nodule of increased uptake in toxic adenoma, and when multiple areas of increase and decrease uptake in toxic multinodular goiter. No uptake if there is thyroiditis. Antibodies are also positive in thyroiditis. Ultrasound scan not very useful, FNA not useful unless there is any compelling suspicion of malignancy, which is not very common in hyperthyroidism. So what are the aims of management? You need to normalize the deleterious effects of excess thyroxine on the particularly cardiovascular system, because that is where people can even die due to arrhythmias or high output cardiac failure. Then also in the long run, we need to normalize the thyroid hormone levels. So the management depends on the cause and also other conditions like the age of the patient, whether the patient is pregnant, other comorbidities, whether the patient has drug intolerance. Antithyroid medicines are mainly given particularly in Graves' disease because some of the patients, about 1/3 of the patients, can have spontaneous remission in this autoimmune disease. So anticipating a spontaneous remission, the thought, the reading and the teaching was to give for about 18 months. Again, this is now changing um, based on certain conditions. We might even go for a definitive therapy even earlier in some of these instances. And also antithyroid medications are used in any form of hyperthyroidism before patient is prepared for either surgery or this should be radioactive iodine therapy, not radiotherapy. And also about side effects. Now, usually antithyroid medications, there are thionamides, carbimazole, and then the methimazole is the active form of this molecule, and also there is propyl thiouracil. Uh, all these have usually sort of common side effects, and usually in thyrotoxicosis we start with higher dose. Unlike in hypothyroidism, particularly in older people, we'll start thyroxine with a lower dose and go up. But in the hyperthyroidism, it's the other way. You start with high dose and then go up. Usual maximum sort of dose of carbimazole is about 15 mg 3 times a day. And methimazole also about 15 twice daily or up. Sometimes we rarely we go up to about 15 3 times. The propyl thiouracil is usually the highest sort of dose is about 150 mg 3 times a day. These are the usual high doses. And then you need to know the common side effects of these drugs. The all these can cause affection of our blood cell lines, mainly the white cells. They can cause agranulocytosis or the white cell leukopenia, mainly granulocytopenia. The severe form is agranulocytosis. Because of that, we need to warn patients that if they get a sore throat, fever, they should consult a doctor immediately and perhaps stop the medicines and come and see the doctor with a full blood count. And then some of them can cause allergic reactions like urticaria, skin rashes, and so on. They are not very dangerous, but sometimes these can also cause hepatitis. uh, the drug induced, you can get a hepatitis. More the both drugs can cause, but it's more severe with propyl thiouracil, PTU. uh, so because of that, we don't use PTU in ordinary patients with thyrotoxicosis. We usually use either carbimazole or methimazole. The indications for PTU are generally specific. We use PTU in thyrotoxic crisis or thyroid storm, because in PTU it's short acting, as well as it has some effect on the peripheral conversion of T4 to T3. And also in the first trimester of pregnancy, we use PTU because PTU, the other two drugs, the carbimazole and methimazole, is known to cause serious side effect of the fetus. Because of that, we don't use that in the first trimester of pregnancy. We use PTU instead. Coming to the other forms of treatment. Now, in Graves' disease, if the person does not get a spontaneous remission within a reasonable time, usually maximum is about 18 months, we need to think about whether we should consider definitive therapy, because of these serious but rare side effects. We usually don't keep people on lifelong antithyroid medications. So the two forms of definitive therapies are, one is radioactive iodine therapy, and the other one is the surgical treatment. So we can use radioactive iodine treatment for as primary therapy in Graves. Sometimes, if the patient seems to be not some countries actually they do this treatment. They just don't want to sort of take by time, because we know only 1/3 of people get spontaneous remission. The others will need a definitive form of treatment. So depending on the place availability, some countries they even think about primary as primary therapy, but in our country we don't do that very often. But mostly in our setup for Graves, it is relapse Graves disease, or if the patient develops some other issues like intolerance to drugs, also we think about radioactive iodine treatment. But when it comes to toxic adenoma and toxic multinodular goiter, they will never go into spontaneous remission usually. So we need to think about definitive therapy from early stage. So after controlling the thyroid overactivity, we will think about radioactive iodine treatment is preferred in toxic adenoma, because usually in toxic adenoma the goiter is not very large. So and also, since this is only one spot that is overactive, a small dose of radioactive iodine might completely knock off that toxic adenoma, and rest of the gland might not get much damage with the I131. So a patient might become euthyroid sometimes without the need for thyroxine later on. And in toxic multinodular goiter, also, if there are no compelling reasons, like if there is no large goiter with pressure symptoms and also no suspicion of malignancy, we can think of radioactive iodine treatment. Thyroid, actually, before going to thyroid surgery, I would like to also give you some contraindications for radioactive iodine treatment. Usually, anybody who is currently pregnant or nursing, breastfeeding, they should not have radioactive iodine treatments contraindicated. And also people who cannot have radiation protection, if there are small children who cannot be kept away for at least about 1 or 2 weeks at home. They don't have toilet facilities separately, and also in women who are frequently engaged with pregnant or young women who potentially can get pregnant. That sort of people. Uh, uh, those are relative, indications for not having immediate I131 treatment. Um, and the other thing is, generally patients should stop carbimazole or other antithyroid drugs about, it depends on the center. Usually most centers would say about 2 weeks prior to I131 therapy, because that you need to have very good um, TSH stimulation, and also the thyroid should be active metabolically to take up iodine. So when you give antithyroid drugs, the thyroid is metabolically quiescent. Because of that, iodine uptake is less, so the effect might be less. Because of that, you get the patient off uh, antithyroid medications, thionamides, before I131 treatment. And also after treatment, again, we usually keep them off antithyroid drugs for about at least 1 week after I131 treatment. Some people can get really a little bit of pain and increased swelling of the goiter. It's called radiation thyroiditis after iodine treatment. And also there can be transient worsening of the eye disease in Graves' orbitopathy with radioactive iodine treatment. Thyroid surgery usually is reserved for mostly for people who have malignancy or suspicion of malignancy or pressure symptoms, or else if the patient with thyroid overactivity have intolerance to antithyroid drugs, and also especially in pregnancy when they cannot have I131 therapy. But the relative implications are, if somebody wants to have a baby sooner, like somebody having been subfertile for years, now planning subfertility treatment, but can't wait, years after, at least, generally it's recommended to have 6 months to 1 year after I131. So if the delay is too much, that such patients can afford for thyroid surgery. And also if there is a goiter which is cosmetically inappropriate, such patients also might prefer to have surgery. So those are the relative indications. Um, so now we will go into thyrotoxic crisis or thyroid storm. Now, this is a severe form of uh, hyperthyroidism, where there's increased mortality, uh, and because of these complications like high output cardiac failure and the predisposition for infection. So we need to have high index of suspicion to recognize promptly. And particularly if somebody has clinical features suggestive of thyroid overactivity or thyrotoxicosis in the preceding days to weeks to months, and somebody have past history or family history of thyroid overactivity or thyroid disorder, they should also have high likelihood if they present with suggestive symptoms. So these are the common presentations. They come with high fever, altered sensorium, tachyarrhythmias, vomiting, diarrhea, also can have cardiac failure, high output cardiac failure, dehydration. So you need to suspect whether it is thyrotoxic crisis if somebody presents with these symptoms. The common precipitating factors are the infection, surgery, and I-131 in a properly unprepared person, and also sudden withdrawal of antithyroid treatment. In the management, you need to provide a lot of supportive care, temperature control, blood pressure control, particularly if the patient has hypotension, and then treating precipitating infection. Generally, we will anyway give them empirical antibiotic therapy, broad spectrum antibiotic therapy. If the patient is agitated, chlorpromazine is a good drug because it has some form of, some degree of reducing the temperature. Preferred antithyroid medication is PTU. We start with fairly high doses like 150 mg 3 times a day. Based on whether you need to again go for urgent sort of I-131 therapy or not, you might think about potassium iodide also. Potassium iodide also would reduce release of thyroxine from the gland, so that might be helpful. Particularly to reduce the effects on the sympathetic system, beta blockers is quite useful in these patients, even if they might have mild degree of heart failure unless decompensated. Beta blockers are very useful because they will reduce the effects on the heart. And also if the patient has mm, like asthma or contraindication to beta blockers, calcium channel blockers like diltiazem, verapamil, unless the patient has very severe heart failure, these are all useful. Steroids also are used empirically because they have many beneficial effects. They will reduce thyroxine release as well as the conversion of T4 to T3 in the peripheral circulation. And also in particularly in Graves' disease, it's an immune disease, so there's some immunomodulation suppression effect from steroids. Uh, Plasmapheresis and dialysis is done in refractory patients. After all these efforts, if the patient is not controlled, they have several mechanisms how they act. They can take away thyroid stimulating antibodies in Graves' disease, as well as they can also reduce active thyroxine from circulation, particularly until the other measures take effect. Right. So next we will go into hypothyroidism. You can send in the as messages in the chat any questions, so we can, if you have time, we can take some questions also at the end. So hypothyroidism, we know that it's due to deficiency of thyroxine in the circulation. It's almost always due to reduced secretion of thyroxine. Causes, iodine deficiency was used to be the commonest cause, but now in countries like us where iodization is mandatory, the salt iodization, it's not the commonest cause. Perhaps thyroiditis, chronic lymphocytic thyroiditis might be the commonest cause now in our setting. But then there are rare ones like congenital developmental defects, genetic disorders of synthesis, after surgery, if you are not replaced properly, after radioactive iodine treatment, if not properly replaced, antithyroid therapy, with sometimes patients just don't comply, with the follow-ups. They go on taking medications, and they come with severe hypothyroidism. Sometimes patients who have had pituitary surgery, pituitary radiation, hypothalamic damage can have secondary hypothyroidism. So if you know about features of thyrotoxicosis, it is very easy to work out the features due to hypothyroidism. So this is due to reduce reduction. It's due to reduction of basal metabolic rate and the thermogenesis, as well as other effects on the sensitivity of the beta receptors. The sensitivity of the beta receptors is reduced in hypothyroidism. So everything will be opposite to hyperthyroidism, because that there is less thermogenesis, there is increased feeling of cold intolerance, and also because there is lesser need for sweating, the skin is dry, and also there's lower sweating, and also skin become dry, and there can be hair fall, cause thin hair can happen. So when everything is slowed down, even our memory is slowed down, we can feel sleepy, our thinking will become slowed down, you feel tired, sometimes apathetic. There's soft tissue swelling of and also soft tissue deposition. This can lead to hoarse voice. The face can become rounded and puffy, and also heart slows down. You can get bradycardia and even heart failure. There is the contraction of smooth muscles in the bowel is reduced, so you get constipation. Similarly, this happens in the uterus, you get menorrhagia. And also the thyroxine is important for muscle function, so you can get muscle stiffness, also muscle weakness, as well as increased weight. So these are typical features of hypothyroidism. So I don't go into detail here. You can see sometimes you will appreciate the effect after treating the hypothyroidism. You see how many people that you might see like this, but you might not think of doing a thyroid test, but see the difference that you can get when you treat such people. This is congenital hypothyroidism leading to cretinism. So aims of treatment of hypothyroidism is to normalize thyroid status and to improve the symptoms. The treatment is almost always thyroxine replacement, T4, triiodothyronine. Very, very rarely T3 is used for short periods, like in myxedema coma, and also in short periods for patients waiting I1 3-1 treatment, particularly in cancer, because in cancer treatment you need to get their TSH to go very high, so that when you give I1 3-1, all the iodine is taken up by the cancer tissue. So the T4 is longer acting compared to T3. So you use T3 in such situations, but this is not available in Sri Lanka, so we don't use T3 in Sri Lanka. In thyroxine treatment, you need to know some principles. Unlike in hyperthyroidism, here, particularly if the patient is older and also have any cardiac disease, we start with lower dose and go high. But if somebody is young, healthy, hearty, also particularly in pregnancy, you start with normal replacement dose of thyroxine, right? And then go high. And the other things that you need to know is thyroxine. Give me 1 second. Um, so this is particularly if somebody is pregnant, we don't need to wait, and usually most pregnant people are healthy. Otherwise, so you start with the usual dose. The other thing is, the important thing is that you should start give correct advice for patients who are on thyroxine. Usually, the thyroxine is we are giving once a day, so the people should take it once a day. And also thyroxine can get affected, the absorption can get affected due to the food. And also particularly this is notoriously can get affected with certain medications like calcium salts, iron supplements, and so on. So we normally advise them to take early morning empty stomach with little water, and ask the patient to wait at least about half an hour before taking any other drinks, even tea or any food. So this is very important when you start thyroxine, giving this advice. And also they should not miss doses. So they have to be very particular about taking doses according to doctor's advice, and also particularly compliance about follow up with thyroid tests. Usually initially you might do free T4 and TSH to titrate the dose, but once the dose is stabilized, the TSH is the test of choice to monitor the sort of the level. Actually, if you want to sort of decide, if you're not very familiar about the dosing, particularly in profoundly hypothyroid person, uh, it's about 1.6 micrograms per kg per day. So you can calculate this by the patient's body weight and give the appropriate dose in a healthy adult or in the pregnant woman. But otherwise, in a very old people with heart disease, some doses that you might think about is about, you can start about, if a normal weight adult, about 25 micrograms you can start. Then very gradually you can ask the patient to increase weekly basis, like 37.5 next week, then 50, then likewise you can gradually increase, because otherwise you can precipitate heart failure in such patients, or also precipitate angina. Also, the other thing that you need to be aware is that hypothyroidism can be co-associated with other hormonal deficiencies like steroid hormones like cortisol in additions is common with hypothyroidism. So what can happen if you start thyroxine in a patient already having hypoadrenalism is that you might precipitate a Addisonian crisis. So if you have doubt, you should not rush, but perhaps test the patient for hypoadrenalism, and then start thyroxine after starting hydrocortisone. But if you are in doubt, there's no harm in an emergency situation. You can start both together, and then you can test later and sort of make the diagnosis. Levothyroxine is what we use, as I said earlier. So there are many dosage forms like this, but in Sri Lanka what we have is 25, 50 and 100. So you need to use these forms in our country. They are micrograms. And then I told you about the other these things. T3 we don't have it. T3 available oral as well as IV. About 20 micrograms is the standard dose. It's the active form, we know, because of that is rapid onset of action. It's rapidly metabolized and usually rapidly become free after stopping the drug. So usually in myxedema coma, we give about 20 micrograms intravenously based on the requirement 4 to 12 hourly. Then we reduce the dose, and then later on shift to thyroxine T4. I think you don't need to know how to dose the T3. It's not usually questioned at your level. Actually, the diagnosis actually of hypothyroidism we didn't deal with initially. TSH is usually adequate as the lone investigation, but if you have any doubt, do the free T4 also, because particularly in secondary hypothyroidism, TSH may not be high due to pituitary disease and hypothalamic disease. So T4 is useful in that scenario. And then in the subclinical hypothyroidism also, when the TSH is marginal, like it's about 4 to 8, with normal T4, we call it subclinical hypothyroidism. When it is more than about 10, we call it overt hypothyroidism. So I told you that in pituitary disease, when somebody is on titration doses of antithyroid drugs, titrating your thyroxine dosage, you do free T4. Free T3 or total T3 is no value in the treatment of hypothyroidism normally. And also TSH can be misleading in certain other conditions like non-thyroidal illness. I told you about recent treatment of hypothyroidism. It takes at least 6 weeks to become normal. Sometimes this can be longer. And in pituitary and hypothalamic disease, TSH secreting adenoma, you can have high TSH as well as high T4. These are rare ones. DNE, all are rare ones. So we have dealt with these things. Usually starting doses in the adults, you can go by what I told about the 1.6 microgram requirement. If the TSH is very high, it looks like the patient has full-blown hypothyroidism. But if the TSH is not very high, you can start with a lower dose. Sometimes like in an adult, you can start with 50 microgram and titrate upwards. Or else, if it is like in pregnancy, very profound hypothyroidism in otherwise healthy adult, you can start with a dose like 100 micrograms, like a usual dose. But I told you about those with heart disease, you need to start with low dose and go increase cautiously. I have dealt with this as well. If you have any doubt about concomitant deficiency of cortisol, you need to treat this or give both together, so that and also in secondary hypothyroidism, since you are not doing TSH, you need to monitor with free T4 at suitable intervals, and then keep the T4 at upper limit of normal level. Subclinical hypothyroidism, I think we will not perhaps ask you questions, so you don't need to be worried too much on this one. But for the interest sake, like particularly in those who are pregnant, who are subfertile or infertile, who are recurrent abortion, these sort of people, or people with severe symptoms of hypothyroidism, we might give them a treatment with thyroxine. Like also in conditions like dyslipidemia, those with intracranial neuropathies like carpal tunnel syndrome, dementia, and cardiomyopathies. And these are some indications for treatment of subclinical hypothyroidism. I think we don't need to go too much on this thing, but it's obvious that you will not give thyroxine for hyperthyroidism or subclinical hyperthyroidism. You have to be very careful in these sort of situations like unstable angina, recent myocardial infarction. So you will not treat immediately, particularly unless they are profoundly hypo, and then again you will go very slowly. Over replacement, these sort of things can happen with over replacement of thyroxine. They can get angina, palpitations, all features of thyrotoxicosis. These are the common things, drugs and other things that can have interactions for absorption as well as metabolism. Things like rifampicin, they can increase metabolism. Calcium, iron, I told you that they can interfere with absorption. And similarly, things like sucralfate and food also prevent absorption. So you need to be aware of these things. Myxedema coma is severe form of hypothyroidism. The issue is that you can get marked respiratory depression, bradycardia, cardiac failure, and severe uh, hypothermia. And also they can get hyponatremia and can be precipitated by cold exposure and CNS depressants. Again, a lot of supportive care is important. If there is airway, breathing, circulatory issues, you need to attend to those things. Gradual rewarming is important, and correction of electrolyte imbalance. If there's slightest doubt or if the patient is very ill, empirical antibiotics, because they might have aspiration, pneumonia, and so on. And usually we don't take a chance. We will give them steroids, and then T3 is the preferred treatment for myxedema coma. But in our setting, we don't have intravenous T3, so we will tend to use T4 with through a NG tube. Coming to the rest of it, goiter. The common causes of goiter are physiological goiter, iodine deficient goiter, multinodular goiter, thyroid malignant goiter, and thyroiditis. I will go faster here because they are not really much to do with pharmacology, therapeutics. So clinical issues are, you can get hormonal abnormalities, pressure effects, the suspicion or true malignancy, and the cosmetic effects. And also, investigate goiter. You generally do thyroid status to see what we are dealing with. Autoantibodies based on whether patient has thyroiditis or not. Imaging, usually ultrasound is the preferred initial form of imaging. Then histology, particularly we do fine needle aspiration guided by ultrasound, particularly if we have doubt about malignancy. So those are the investigations. Management depending on the cause, hormonal status, other comorbidities, and the personal preferences. Coming to thyroiditis, there are three common forms of thyroiditis. The commonest is the autoimmune, we call it Hashimoto's or chronic lymphocytic thyroiditis. Then there is this post-viral or decovenous thyroiditis or subacute thyroiditis. Some people can have other rare ones like postpartum thyroiditis. The clinical issues in thyroiditis are, in the post-viral or subacute, you can get pain, then fever, constitutionally they can become ill. The goiter can be an issue. Usually transient thyrotoxicosis can happen because of the release of thyroid hormones. And on the longer run, people become hypothyroid. So this can follow a period of transient hyperthyroidism. So the management depends on the clinical issues. Thyrotoxicosis, you need to usually treat symptomatically with beta blockers and so on, because it's not due to the synthesis of thyroxine. If the patient has very severe pain of the thyroid, anti-inflammatory therapy like NSAIDs, and if the patient is having severe pain and also not responding to anti-inflammatory therapy, you can give a short course of steroids. If its patient has hypothyroidism, its replacement. Sometimes there can be a slightly higher risk of malignancy on the longer run. So if there's a goiter, periodic surveillance with ultrasound and clinical examination might be important. I think that is what we are going to discuss about the therapeutic aspects of thyroid today. Any questions that you all have posed? Yeah, there's a question, is in both hypo and hyperthyroid soft tissue swelling is noted. Actually, you can get Graves ophthalmopathy both in hyperthyroidism as well as hypothyroidism, as well as in euthyroid patients. But commonly it is in hyperthyroid patients. But we see euthyroid or hypothyroid people with Graves orbitopathy. So this is, you need to understand that. Yeah. Somebody has asked to mention antithyroid drug doses. Usually, if somebody has very severe thyrotoxicosis, we give them dosage like if it is carbimazole or PT, the methimazole about 15 mg 3 times a day. OLC even you can do because they are long acting, twice daily dosage. And if it is PTU in the profoundly hyperthyroid, you give 150 mg 3 times because it's again short acting. If the patient has not very severe hyperthyroidism, based on your clinical judgment, you can start with a lower dose as well, if particularly if the patient has not got severe tachycardia and so on. So somebody has asked, is it mandatory to do lipid profile in hypothyroid patients? Actually, if somebody has come with um, a lipid profile, a hypothyroid patient, that's fine, but don't treat the dyslipidemia until you treat the thyroid, replace the thyroxine, because these patients uh, uh, can get rhabdomyolysis when you give statins in profoundly hypothyroid patients. Your replacement of thyroxine will anyway normalize the lipids in a person who is having elevated LDL and so on. So wait a month, wait for at least 1 month before you do the lipid profile, and then if still there's indications to give treatment despite replacing thyroxine, you can decide, but not otherwise.
Services. And I would try to weight that basket based on how people actually spend their money. So I'd say, okay, 40% of people's money on average is spent on housing, maybe another 10% is spent
There's some
on transportation, maybe another 10%
interference sound.
spent on food. And I would go out into the market and I would try to take an average of what these things cost. And I would sample a bunch of products, a bunch of services, so I get a decent average of that.
Supurna, there is a, what is that? And then so usually actually the common recommendation is about 1 year, but some centers I have seen about mandatory 6 months that they have to avoid being pregnant. So definitely it's safer, at least for them, unless there is a major sort of history of subfertility or something, to be at least 1 year after I-131 to be not getting pregnant. Right. So I think that is all up for today. We will then have the next lecture, I think on 15th at 4 p.m.